Perfect. I'm Alex. I'm one of the PAs with Summit Brain Spine Orthopedics, working primarily with John Edwards. First and foremost, just recognizing the ortho night last week. I was surprised she didn't say much because I thought it was a great event. So thanks for everybody that came out and participated, and we got to learn about plantar fasciosis, which was a new term I didn't appreciate until last week. So today, the point of the discussion, we're going to talk one specific pathology for a few minutes, but the principles are universal. So the idea is to have a discussion to get everybody's input and everybody's experience of how we address these similar situations throughout all the different settings in medicine. So, yep, no disclosure. I wish, one day. This was the patient that came to my office. This was, I think, back in December, not too long ago, just a few months ago. 35-year-old female, past medical history of endometriosis. She comes in for low back pain. Raise a hand, has anybody treated somebody with low back pain before? Okay, so we've got a few experts in the room, which is great. Symptoms started in October. She's talking about progression. So I saw her, I think it was December, so just over 2 months. That's when she's really noticed it start to get worse. She's experiencing symptoms in the right leg as well, primarily pain is what she's talking about. And then she gets headaches off and on, not sure if that's correlated or related, but something that she brought up. It starts to wake her up at night, the pain in the leg as well as the headaches. She's starting to have troubles with just basic activities and then some of her essential duties at work, which is what triggers somebody to come see the doctor. She's tried ibuprofen up to this point. It's been mildly helpful. Does anybody have a similar scenario? Have you seen this patient come to your office before? Something similar to this, okay? Any differential diagnosis at this point?
So with their endometriosis, when it's bad, does that give her back pain?
Yes, great point. So she had been worked up prior to this with her OB and with her primary care, primarily focusing on that. So that's been her focus up to this point. So that was one of the leading theories.
What about motor loss, difficulty using your legs and stuff like that? You talk about just leg pain. Is there anything else involved, muscles?
Yes, we'll get to that. Just give me your differentials though. What are your differentials to this point? Before you get any more information.
Jump ahead.
Yeah.
My mind is starting to get out here.
Just basic things, what would you assume might be a problem here?
Herniated disc.
Great. Herniated disc, that would definitely be on the differential. Anything else?
Sciatica.
Sciatica.
Lumbar radiculopathy.
Yep, radiculopathy. Okay, so pretty basic stuff. We see this all the time. Physical exam. This is not the entire exam, okay, but the pertinent pieces. So she's 5'2", 114 pounds. She's a small lady. BMI is 20. Heart rate was up a little bit that day in clinic, but oxygen normal, temperature pretty normal. All of her sensations intact. She's got 5 out of 5 strength. Reflexes intact. Negative straight leg raise. So all of that we're trying to tease out what we're talking about: radiculopathy, sciatica, disc herniations, okay, and all of it on exam is fairly negative. That patient population also talking about localized back pain. We run through some of the SI provocative maneuvers, had 3 out of 5 positive. Any differential diagnosis at this point? Is this steer you a different direction at all? Would you think any other potential pathology?
You mentioned SI joint before, but what are the provocative maneuvers that are positive? Were there 5 provocative maneuvers that you were using? Or?
There's 5 total. 3 of the 5 were positive. We put that on there. That's kind of the hot phrase for insurance, to recognize that as a legitimate diagnosis, at least 3 out of 5 provocative maneuvers. I'd have to go back and look exactly see which the 3 were.
I don't even know what the 5 are. That's what I was wondering, what 5 maneuvers are there?
Yeah, so standard maneuvers, there's a distraction test, a thigh thrust, a compression, Faber, and Gainsland's are the 5. Dr. Freeman actually did a great presentation a few months back about sacroiliitis. Anyway, okay, so still a lot on the differential. She came with a pelvis MRI is what she had, okay, because again, she had primarily been working with her OB in primary care, and endometriosis was the leading theory. So she had a pelvis MRI is all she had. Do you guys see anything interesting there? Just an axial and a sagittal view of a pelvis. I know if you don't look at these a lot, maybe you don't always see.
Just a bunch of perineal cysts.
Yep.
Tarloff cysts.
Good, yep. Okay, so she's got a lot of cystic structures through the sacrum area. Okay, what would you do next with this patient?
Refer them to you.
Yeah, that's what happened.
Coddle.
Okay, so, give us a little bit more about that.
So, I mean, you're in the sacrum, so you could try a coddle epidural. I don't know how you'd reach it otherwise, or at least cover any of those with any anti-inflammatory
Yeah.
effect. But I'll just try it and then send it to you.
Yeah, yeah, it's a good option. Yeah, I appreciate somebody trying to be proactive and trying to treat. So if you can see, my thought was that the cyst is actually still outside of the field of view. So the idea was, let's have her finish the imaging and let's evaluate the rest of that cystic structure. How high does that go? Is there anything else involved? So we sent her for a lumbar spine MRI scan. So she comes back to clinic a couple weeks later. Now she's saying, just over the last few weeks, I've got worsening headaches. My leg pain's getting worse. I've had to clock out at work. I couldn't finish an entire shift because the headaches get so bad. I can't sleep hardly at all. The pain keeps waking me up. And then just the activities of daily living are getting worse. Okay, we'll kind of jump to the chase because we had the MRI scan to lumbar spine. This is now lumbar spine MRI.
Quite large.
It's a lot of cysts.
Impressive.
Impressive, that's what I thought.
Yeah.
See a lot of white.
Yes.
Lots of lytic changes within the bone, concern for foundational destruction.
Yeah, which bones are we talking about?
You can see sacrum, both in the front and the back.
Mm-hmm.
On one portion of the pelvis MRI, there's exposed
Yep.
cysts posteriorly.
Yeah, they're huge. We're talking multiple centimeters and kind of encompassing the entire sacrum. Okay, how about on the axial scan, which is the far left? So this is typically what I would say is the central canal,
Right, pressing on the nerve root.
and the thecal sac is way up here. Okay, so it's completely displaced the thecal sac. So reasonable to say she likely does have some radiculopathy associated with this. Okay. The diagnosis here, what these are called, Dr. Chappell alluded to this, perineural or Tarlov cyst is what that is called. They're benign spinal fluid-filled sacs located in the nerve root sheath itself, typically between the two layers, the perineurium and the epineurium, near the dorsal root ganglion. This was first described in the literature back in 1938. Obviously, Dr. Tarlov names it after himself. But since then, really consistently labeled as an incidental finding. We just see them, they're there, but the thought process is likely has been there a long time and for the most part thought to be asymptomatic. The key differentiating factors with this, or the characteristics, is that there's actually presence of nerve fibers within the cyst wall itself, or the nerve roots extending into the cavity of the cyst, and then most common in the sacral nerves, like we were seeing there. Causes are not completely understood, but the leading theories with what would cause these would be prior trauma to the area, a connective tissue disorder, and then an inflammatory process that kicks that off. Typical clinical presentation, 86% of these are in females, and then 80% of them between the age 31 and 60. So we had a 35-year-old female, which fits right in there, and it's all through the sacrum. About 5, I read a few different things, but I think generally accepted about 5 to 9% in the general population. So these are out there. There's a fair amount of them out there. We see them fairly often, especially spine being primarily what we do in our office. We see it quite often. But of that 5 to 9%, really only, we're talking single digits, 1 to 5% of those are thought to be symptomatic. So the odds of this actually being the primary symptom generator are actually quite low. And again, usually when we see them, it's considered an incidental finding. Symptoms of this can be all over the place. You can have radicular pain, weakness, localized back pain, typically around the sacrum, headaches. The thought there is that it's influenced by pressure, spinal fluid pressure when you're upright, kind of similar to a spinal headache, constipation, incontinence, everything through the sacral area, sexual dysfunction as well. And again, highly variable depending on size and location. Just to give you some comparison, other common cystic structures that we see. Any guess on what that one would be? This is not our patient. I stole that off the internet, but we had a patient we operated on last week that had almost an identical looking scan. I know, yeah, it looked identical. So I stole that off the internet. I had the same thought. Any idea what that one would be? Does it look the same? Similar, but not quite the same. Yeah, this one is a synovial cyst. Okay, so that's synovial fluid coming out of the facet joint. Okay, also compressive lesion. This one, other cystic structure in the spinal canal. This one we call an arachnoid cyst. Okay, similar appearance. I would say that's the most similar appearing one on a scan, just typically mostly through the central canal rather than out in the nerve roots themselves. So what do you do with this patient when we've got significant clinical presentation, somebody's struggling in life, and your diagnosis is, we're calling this a perineural or Tarlov cyst, but traditionally they're meant to be really, really rare, and even more rare that they're actually symptomatic. So this is the situation where somebody's struggling and you have a diagnosis that maybe doesn't allude to great treatment options. So the algorithm starts with, is it symptomatic or asymptomatic? Okay, in this case, likely a symptomatic Tarlov cyst. Okay, is it a surgical problem or is it a non-surgical problem? Have you exhausted conservative measures? Is this something you're really wanting to dive into surgically? Okay, chiropractic care. Is anybody with the last name McLean in here that could comment? What would you do with this patient in your office? How would you be helpful for this patient presentation?
For the cyst, I have no idea. I usually send them to you guys.
Okay. If somebody just generally shows up though with back pain and something maybe we're just symptomatic management, are there options you feel to be helpful?
Well, generally the back pain, yeah, we're gonna take X-rays and biomechanics and try to find out what the pain generator is.
Okay. Yeah.
Usually, though, the patients know they have a Tarlov cyst because it's been read on an MRI, but they get worried about it, and most of the time, we don't do anything about it.
Yeah.
And think they're probably asymptomatic and don't need any treatment. So, one of the general things is the reassurance and education about Tarlov cysts usually are not treated surgically and generally don't cause a problem. This one's a little different,
Yeah.
because of how much bone erosion and the effect on the nerves. But by and large, they're well, reassurance and a little patient education.
Yeah. I appreciate that. I was going to get to you next. Physical therapy. Any options for treating? Yeah.
I had this patient, actually, not that one, but
Yeah.
it was tough. They didn't really know what was going on with her. I don't know who they were in this case, but it seemed like she would just cycle from better to worse to better to worse, and then she'd come back like a month later, it's like it's worse again. It was tough. We just worked on, as much positioning strength as we could without exacerbating irritating symptoms. She was a young mom. She was she was a little bit younger than 30, I think, but eventually she came back about a year and a half later and said, "Oh yeah, no, they found a Tarlov cyst, and I had to go to somewhere." And
Yeah.
I took it out, and I'm 80% better. I'm like, okay, great.
Yeah. Good. How about the interventional pain guys? If Dr. Partridge shows up, we got to pick on him. So I can give you a preview. I asked 3 or 4 different colleagues in pain management what they would do with that specific scan. But any options that you would have if that patient came into your office?
If I saw that MRI, I wouldn't do anything with it. It's just too big, and the chance of me getting any symptomatic relief with it to drain that one's really low. But I have had several that have had much smaller cysts that were accessible with the needle and with the low risk, and so I've drained those before. And in those cases, when it's like near a nerve root, it tends to improve their symptoms. But 9 times out of 10, the symptoms return weeks or months later. And it's probably not the best idea to continue draining that cyst for the rest of their life. So usually, if it recurs, I'll send them to you guys as well.
Good, yeah. And that was a consistent message I got from other colleagues in interventional pain management. And that's consistent with the literature as well that discussed a few options of intervention there, likely to be helpful, likely to recur. Okay, and then surgery. We also have a neurosurgeon in the office. What would be the surgical options? Are these ever treated surgically?
I don't know. I've never operated on one. I think I'd probably just make it worse. I have a question though. Has anybody ever injected like a fibrin glue into the cystic structures? Because if there's some communication of spinal fluid and it has the potential of enlarging, getting into the cyst and injecting some sort of sealant, if you will.
Right. No, I think that's a great idea, but I'm not sure it's been.
Yeah, I've read about it a little bit, but I've never done it.
Yeah, I haven't done it. No, I haven't seen it done, but.
The issue with operating on it is that it's almost like, what are you really going to do? You could open up and dissect all the adhesions and arachnoid, and then I think you'd just be looking at a big open cavity with very few options for closure, and it's a very high risk of creating a spinal fluid leak. I wonder if her headaches are coming from displacement of spinal fluid into the cyst as she gets up, and so there's definitely a fluid dynamic issue. But I probably would handle 90 to 95% of the patients that come through our doors through this population, but there's a percentage of patients where they need a more expert surgical opinion, and so that's what I ended up doing with her.
Yeah.
Is seeking some advice from other surgeons in the area.
Yeah. And how did that play out then?
Yeah, so that was very interesting. So I presented it to all the surgeons in Utah. Get together about twice a month and discuss cases, and I showed them the case, and every single one of them said, yeah, I wouldn't do anything with that surgically. You need to send them out of state. So that was the answer.
Yeah. Okay, so now we're into this situation where you've got a patient that's coming to you as a medical professional that needs help. We've got a realistic reason for why they would be struggling a little bit and need that help. But getting some feedback from all the different specialties we've got involved here, it doesn't sound like we've got a great option to really intervene and be helpful. So, a couple hopefully thought-provoking questions to kind of lead the conversation. It doesn't necessarily have to be about the pathology that we discussed, but this has to come up, I think, regularly and universally throughout medicine. But if the ideal treatment's outside of your immediate scope of practice, what factors typically come into play here in your decision making to try and send them out or not? Because I can see both sides of the coin here, but I'm interested in what your thoughts are.
So if something's, even if maybe it's on the border of what you're capable of treating, and you want to expand your capabilities, I think it's always a good idea to consult with a colleague or a group of colleagues. And I know there's probably forums in all the different specialties for this kind of thing, and I think there's a tendency to sort of hold on to cases and not reach out, but there's a huge advantage to doing so. And maybe it's a little vulnerable, maybe some people might say, well, why didn't you know how to do that or something, but usually I've found that the surgeons or other surgeons are very eager and willing to help. And then if you do refer, for me, if I refer a patient, say, to the university or someone else, they're usually very gracious about it, and then you can learn through that. So it's been a good thing to do.
Yeah. Good.
And ultimately, the patient's going to be satisfied. We had a similar situation. We operated on a patient, and there was some pathology for which we could not explain, and the decision was ultimately made to refer to another surgeon up at the U, and that patient just messaged back about how grateful she was for our willingness to treat her, but then also get other eyes on. So I think it's important that we don't lose sight of that. I think ultimately it's the patient's well-being that we're most invested in, right? So sometimes we got to put our pride aside.
Agree.
And then as far as back pain, radicular pain, these things, there's a lot that's outside of my scope of practice. So I can come to biomechanics, but I think my patients, when I talk to them and tell them, they wonder, am I in the right place? I tell them, well, this is my team with PTs and the surgeons and the pain doctors, and we're going to refer you for these things if this is what we feel that it's going to be best for you. They love it, and they're happy to then do what we can do, and then we know that we're going to refer them when they need it. They really like to know that I'm not just going to hold on to them. I'm trying to do everything I can.
Agree. Playing, I guess, devil's advocate a little bit, what if the patient just says, but Matt, I trust you, I just want to work with you, I don't want to wait 6 weeks to go see a specialist, can you just help me?
I've had them say that, and I said, in this case, you actually need surgery. And they're happy.
Good.
I push them. They're like, because they actually have to know. They do say, "Well, I trust you because I know that you're not just you're not a surgeon. You want to just cut on me, so you're going to send me if I really need it." And so since I send them because they actually I know that they need it, then they usually go along with that.
Good. Yeah.
So I was going to say part of why we're here is the inter-collaboration, right? So I've leaned on you guys several times where I've messaged in situations similar to that where a patient's coming in and they're wanting something done now. And I'm like, wow, okay, well, let me message so-and-so and see what we can expedite. And you guys have come through a bunch of times. So I think that's partly why we're here, is to collaborate and to be able to lean on one another. But there are challenging times where patients don't necessarily want to hear that, but ultimately it's for the best interest of them.
Good. Have you ever kind of going along, these are all going to be pretty similar questions, but felt pressured to manage a patient or perform a procedure that kind of pushed the limits of your comfort zone? Has anybody ever felt that? This week. Okay, does anybody kind of relate to that experience?
We just had a patient that came in. She came in, it was the husband. He came into the ER here and had a melanoma metastasis to his frontal lobe, and it was intraventricular, and it was really close to the thalamus, and it was like almost 6 centimeters. And so I was in surgery here, and they called me, and I said, yeah, that's not something that we would manage here. We should transfer the patient. And then I got a call a few hours later at Utah Valley Hospital. Your patient's here, and I knew that I knew I was capable of doing it, but it was definitely a tricky spot, and it would have been tricky for anybody. And so, there's definitely the moments when some problems were just harder than others, and fortunately he did very well in life.
Good. Yeah, good example. Anyone else? Yeah.
I think you have to be honest with the patient. If you have a situation where you're not comfortable, you have to be able to tell them that you're not. I think that's an area of vulnerability, but if anything, it shows that you're putting them above your own thoughts. I mean, frequently we'll see this with physicians who are taking call. I see it with a lot of orthopedic surgeons that will come and call, and they'll have a hip fracture and they have to do a total hip, and they don't feel comfortable, and there's a pressure for them to treat it, to not ship it, because I don't want my standing in the community to drop because I'm an orthopedic surgeon. I should be able to manage a hip fracture, but there's some that just it's not comfortable. And at the end of the day, the most important thing is to emphasize to the patient what you're comfortable with, because again the question becomes, if this were your family member, would you want a doc treating them
Yeah.
Gary and I were talking about this over the weekend because he was describing how one of the really experienced trauma surgeons in orthopedics will oftentimes have Gary do shoulder stuff. And we were talking about how in orthopedics there's more of that than in neurosurgery. The neurosurgeons tend to hold on to cases more, and maybe we would be better off to collaborate better. And for whatever reason, it doesn't happen as often.
Yeah. Yeah.
I think we all, I think, feel the same, so I'm just echoing some of their comments, but there is a little bit of vulnerability when saying you can't manage it. My presentation to the patients is just like, look, you came in, you're trusting me with your care, so whether you like what I'm about to say or not, I'm going to tell you what's best for you based on my experience. And usually that's you need to go see a surgeon. Well, I don't want surgery, I want to come see you. Yeah, but in my experience, I can spend 10 visits and you're not really going to get better, and you're going to be mad at me at the end of 10 visits when you still need surgery. I think sometimes just being honest and say, look, like, this is the best place for you to be, and I'm going to send you to the best person that I can find within my network that's going to manage this for you. And even if that means I only see you for one visit, which happens a little bit in our practice, like one and done for us, like you're not in the right place, I need to get you to the right place. You'll be much happier with me if I get you better, even if it's just with a referral, than it is if I try to just manage this situation that is maybe outside my scope or needs different intervention.
You're actually managing it rather than the difference between management and treatment.
Yeah.
You may not be treating, but you're actually managing the case.
Yeah. I like that. That's a good way to summarize that. Good. And then right in line with that, where do you draw the line then of really giving your best effort to provide the help needed? So a patient comes to you, they trust you, they want your help, and not just having the reflex to see that it's too complex or maybe going to push you a little bit, but also not going too far outside that level of expertise. I guess what's the other side of the coin of when do you feel comfortable trying your best to help them?
I think we see this a little bit as a primary care, mostly geriatric medicine is what I do now. Oftentimes I have these patients in like skilled nursing facilities, and they've seen hundreds of experts already before they've come to me, and they're like, okay, I just want you to do the pain management, I just want you to do these things. And something that's helped me a lot in the past is, luckily I have people on speed dial that I can be like, hey, I need this patient in, which helps with the intercollaboration, but also just building that trust with them and then being like, okay, this is where my expertise is, and I have my partner here that has this expertise. Like, let's work together with them to make sure that we're giving you the proper amount of care. And what I've noticed lately is that a lot of them have seen specialists that have held on to them and maybe not given them the care that they actually need, or the care that they want because they've held on to them. Mm-hmm. And so I think just making sure that, I think it's also just understanding your limits. You know, we all have limits of what we can do as a provider, and it's nice to be able to provide out to like Dr. Pitts or to Dr. Edwards to just be like, you know, I think this might be what's going on, and we've tried these things, but can you just give me your second opinion on it?
Yep.
So that we can make sure we get the proper care. Because in the end, like Tyler said, it's the patient. Regardless of what we think about ourselves, the patient comes first. And if we can try to help them, then we've made probably the difference in their life.
Good. Yeah, it's a difficult balance. We want to be helpful for people. I think everybody here provides a benefit to the community, which is great. It's great to see everybody come here together. And I think the patient wins as much as we really rely on each other. That was an interesting question. We're done though. We'll finish. William Osler, the father of modern medicine, said, the good physician treats the disease, the great physician treats the patient who has the disease. So ultimately, the patient wins. We're looking out for the patient's best interest. And thanks for coming.